Good day everyone, I'm John, moderator for this webinar. Welcome everyone for today's webinar, CMS CAH swing bed requirements and changes. I would now like to introduce our presenter for today, NASH Healthcare Consulting, and one of the best speaker of NASH, Susan Selly. Over to you, Susan.
Okay, good afternoon everyone. Thank you for attending. Just to give you a little bit about my background, I am a registered nurse for over 40 years. I've been doing consulting for over 25 years. I have a lot of experience in critical access and acute care hospitals. I will hope to impart some of that knowledge to you today. Okay, so we're talking about critical access hospitals and swing bed programs. And for those of you that don't know why we're making sure that we're aware of all the regulations here, CMS is the oversight for these programs, and CMS comes in periodically under complaints or issues that might have come up regarding your facility or your programs, and they will then issue what's called a statement of deficiencies and require a plan of correction. So we're going to talk about the critical access hospital conditions of participation in the Medicare program. There are 4 changes back in November of 2019. Those regulations are in Appendix W. Appendix W is the standard operation manual for critical access hospitals. The significant changes have to do with how they interpret those specific guidelines and procedures, and if you really want to look at the minutia of how they will interpret them or survey them, you will need to go to the long-term care manual. How do you keep current? Make sure that you stay abreast of changes, because as they occur, you want to make sure that your policies and procedures are up to date. You want to check the survey and certification website monthly, and those links are here at the bottom of the slide. The manual first came out in 1986. There's been multiple updates. The section numbers are called tag numbers. They start in the Federal Register, where there's the interpretive guidelines and survey procedures. So here's just what the State Operations Manual Appendix W, the cover page, looks like. So we're just looking at pages that are the long-term care manuals. This is one of the memos that came out. This was for Appendix Q. Now, the CMS Surveyor Worksheet for Swing Beds, Form 288. If you go into cms.gov website, you should be able to pull up the worksheet. It gives them crosswalks for what the tag numbers are and how to look at the assessment for swing bed regulations. Okay, so here's the Surveyor Worksheet. This is just a sample of the top of the worksheet. There are lots of resources out there for critical access hospitals. Here's a module number 4 about rehab services, another module, different medication lesson, medication administration, monitoring. So there's lots of information that you can access out there for training. So let's talk about swing bed deficiencies. So deficiencies that come up when surveyors are doing surveys of critical access hospitals and smaller hospitals and their swing beds. These are the things that they're looking at specifically that they're not finding, or if they find them, they're done improperly. So we're just going to go over some of that information here. Some of them have failed to inform residents of their rights orally and in writing, failed to inform non-English speaking residents of their rights in a language they can understand, failed to allow residents to get copies of their medical records, failed to provide interpreters so a resident would understand, and no policy to advise on the difference between inpatient and observation status. Going back to Appendix A, for hospitals, contact if they have a question. Just the right to know your doctor's name and who's taking care of you. Reporting abuse and time frame to do so was changed. The plan of care with issues and clarifications. And the PASARR clarification, it's never been a requirement to do one, but if you have a patient that could have behavioral issues, you may want to do the pre-admission screening and resident review to make sure that they're a good fit for your swing bed, because if you can't provide the services they need for behavioral, the majority of the content is under patient rights. Information that you'll need to provide. CMS refers to Appendix PP for the interpretive guidelines and survey procedures. So you would look under the F standards under the long-term care manual and look at how they're going to survey your facility for swing beds. So other rights are in the Appendix PP. As I said, you look at these rights and they'll go into much more detail. Transfer outside of the facility. Now we're going back to those critical access tags. This is under 1610. The purpose of this regulation is to restrict transfer by facility to prevent dumping of high care or difficult residents. So as I said, you must develop a comprehensive care plan. Any specialized services, if you do use a PASARR, and that's part of the federally mandated screening to assess people with mental illnesses, for nursing facility placements to determine if that facility is appropriate. You don't have to use this, but if you do use it and you disagree with the recommendations, you must indicate the rationale in the patient's medical record. You want to include the interdisciplinary team. 1620 is the tag number in critical access. The resident's representative should be consulted about any goals, any desired outcomes, and then preferences and potential for future discharge. Try and schedule meetings at convenient times for both the team and the resident, and consider bedside conferences and rounding. Review and revise as necessary after each assessment. That's the care plan. If you change the assessment, something has changed in that patient's care, the care plan should be amended. Services provided by staff should be culturally competent by qualified staff and meet standards of quality. The comprehensive care plan, now going back to the F tags, which is in Appendix PP, it's going to go again into the same things that we talked about. Baseline care plan should be developed within 48 hours. Now again, we're talking about long-term care here, but baseline and minimally, your information for the patient is there at the time of admission to the swing bed. You would have initial goals based on that admission orders, based on the physician's orders, based on dietary orders, based on any therapies that have been ordered, and any need for social services. So you can initially start a care plan immediately because you would have that information. There's never been a requirement to do the mental health screening. There's not a requirement to complete one now. If the resident has one, you want to incorporate it into the care plan. If they've been in a long-term care facility, they should have had an RAI done in the long-term care facility, which you can review that and include it in your plan of care. The physician must document that the information is communicated to the receiving provider or facility. Looking at trauma patients, are any specific considerations if the resident is recovering from trauma, including the resident was a trauma patient. So the care plan must be culturally competent and trauma-informed, must make reasonable attempts to provide services, again, keeping patients in touch with facility agreements with facility, with the communities, with the religious practices, maintaining contact with friends, all those types of things to help patients retain their autonomy. If they have any specialized rehab services, that's part of the plan of care. Obviously, 1622 is again the critical access hospital manual. So here's just signs of dehydration and education for the staff. The parameters for weight loss, suggested weight loss as part of your policies and procedures. We have gotten to the end of the slides portion of the presentation. Okay, well, again, as I said before, thank you for having me for this afternoon and listening to this presentation. I hope that it's given you some information that you need. If after the presentation is over and someone has an additional question, it can always be forwarded to me.
Thank you very much.